Hi, I'm Gavin Giovannoni, a neurologist based in London, and welcome back to the Moving Science series of podcasts. Today I'm joined by three international experts where we'll be discussing the clinical value of neurofilament light chain assessments in the care of multiple sclerosis, both today in the current tense as well as in the future. So, Ahmed, would you like to introduce yourself?
Yeah, thank you so much, Gavin. So I'm Ahmed Obeidat. I am a neurologist in Wisconsin in the United States. I practice at the Medical College of Wisconsin. I'm an associate professor, and I do research in multiple sclerosis, and I see patients, and I'm very also passionate about education. So that's part of my career at the medical college.
Sharmilee?
So my name is Sharmilee Gnanapavan. I'm a consultant neurologist at Barts Health with long-term interest in biomarkers, both on the bench side, but also in the clinical applicability when it comes to multiple sclerosis. So this is very relevant to me currently.
And Tanuja?
Hello, my name is Tanuja Chitnis. I'm a professor of neurology at Harvard Medical School, and I have been working in the MS field for over 25 years. One of my focuses has been biomarkers in MS, and I direct the Klein Biorepository at the Brigham and Women's Hospital, where we have studied biomarkers.
So thank you. So let's hit straight in. Sharmilee, maybe you could start because you did your PhD on this project many years ago. Can you tell the listeners what is neurofilament and is it a biomarker that's ready for prime time in multiple sclerosis?
So neurofilament is a type of intermediate filament which is present in neurons. This could be either in the central nervous system or peripheral nervous system. It's quite specific for neurons. So when you do have any damage to neurons, you will find that neurofilaments are released where they can be measured either in the CSF or in the blood. So as a biomarker, it's very specific for neuronal injury and therefore would be very useful in clinical practice in MS. So over the last couple of years, a lot of data from various groups has come in, both prospective as well as retrospective analysis, which have shown the utility of NfL as a biomarker in MS. So I do think it is now prime time for use in clinical practice. Now, obviously, the noise of the test needs to be considered. So, for example, in the blood, it is not as sensitive as you would want it to be based on the basis of assays which are available. But really, if you can look at it more longitudinally, we may be able to kind of factor in the issue with the noise more in the long term.
Tanuja, in terms of, I mean, Sharmilee's mentioned the sensitivity in terms of it being quite a sensitive biomarker for damage. How specific is it for MS? Do you think it's going to be able to sort MS out from other comorbidities, for example?
Yes, Kevin, that's an excellent question. And NfL is not specific for multiple sclerosis damage alone, since it's a marker of axonal and neuronal injury. It can be elevated in Alzheimer's disease and Parkinson's and ALS with head trauma and also with stroke. So it is a fairly non-specific biomarker of neuronal damage. And we have to take that into account as we're interpreting NfL values. It also can be altered and increased with peripheral neuropathy due to diabetes, and levels can be affected by states such as pregnancy, increased BMI, and also with renal dysfunction. So these are things we have to take into account as we're interpreting NfL values.
So does a high level or a normal level have any prognostic value in MS?
Yes, so there's been a number of studies, and this is very exciting work that's taken place over the past 5 to 7 years, showing that NfL is increased when there is a new gadolinium enhancing lesion on MRI, and that's probably its strongest association. And it is also increased when there's a relapse with a new lesion associated with it. And when we look at its prognostic values, can it kind of prognosticate having new inflammatory lesions or relapses? It can to some degree. And I think the paradigm is that if you are having inflammatory disease activity, it's reflected by NfL, and that in itself predicts having new inflammatory disease activity. So yes, it can be a prognostic marker of new disease activity happening over the next 2 years. And that's generally what's been shown in studies.
This would be quite exciting in terms of trial design. Can it be used as a surrogate endpoint in clinical trials? And the real question is, will the regulators accept it as a surrogate outcome in clinical trials?
Yeah, great question, Gavin, about this, because, thinking about what would be a surrogate endpoint and how can something qualify to be a surrogate endpoint, I think in my mind, if it is very clinically relevant. And as we heard from Tanuja, and that this endpoint could actually correlate with clinical outcomes, and more studies are actually showing that there is a clinical correlation with EDSS, correlation with relapse rates and MRI activity. And as we've heard, it can predict over 2 years or over more, actually sometimes longer, that what a patient may have as in relation to progression. So the more we see correlation with clinical outcomes, the more likely regulators will consider it as a valid and reliable outcome measure. So currently, as we know, relapse rates, MRI activity, EDSS are most commonly utilized outcomes. But NfL has shown to correlate in various studies with, as we mentioned, relapses, MRI activity, and more recently with also disease progression. One of the interesting papers I read actually last week, that in people who had B-cell depletion, so they are on B-cell depleting therapies, they actually found a correlation, or in a way to predict in 10 years if they would have progression independent of relapse activity, or what we know as PIRA, at 10 years if they had an elevation of GFAP, which as we know is glare fibrillary acidic protein, which is another biomarker. But when they have this elevation in it and a combination with no or little decrease in NfL levels over time, so those patients, despite being B-cell depleted, they actually showed more progression over time. So it could even show us some prognostic value when combined with other biomarkers. So back to the question of the surrogate outcome, the more correlation that we see and publish, it's going to be likely to have it as an outcome measure. But I personally think that it is unlikely to be a primary or a surrogate outcome for clinical trials, just because multiple sclerosis remains a clinical diagnosis and a disease of high clinical relevance. And if we actually are depending on a biomarker to be the surrogate endpoint, then maybe that may not translate in all patients into a clinically meaningful impact. So that's one of the things I always like to think about is, if we combine it with clinical outcomes, it has great value. It's a great tool to have, and it should be incorporated in clinical trials as an outcome measure, but in my opinion is not a replacement of the clinical outcomes, but a complementary biomarker to clinical outcomes. So maybe regulators will kind of start looking at it in clinical trials as a very valid point for combined with clinical activity.
So I think one of the good news things for us is the FDA gave a provisional approval for ALS, motor neuron disease therapy, on the neurofilament results, and that was a provisional. So the company's going to have to do some more work to get a clinical outcome, but at least they're beginning to think about it in another disease area as a surrogate output. Now, Sharmilee, one of the problems, Sharmilee, we have, is can we use absolute levels? Because I know that a lot of people are pushing towards the so-called Z-score. And how do we use the actual levels? In clinical trials, we have group data, which is fine, but at an individual patient level, what does it mean, an absolute level versus a Z-score for people working in the field?
So this is a very difficult proposition when it comes to biochemical tests. There is always a process of trial and error before you get to the correct way in which you say what is abnormal and what is normal. So traditionally, biochemical tests use simple cutoffs because that's what the layperson understands, clinicians will understand better, where you have a normal range and then an abnormal test result is based on that normal range. Now, obviously, we've moved on a lot further as far as NfL is concerned, and we realized, in fact, that a single cutoff may actually exclude a large proportion of patients who may have an abnormal results, but because our cutoff is not that stringent, or it's too stringent, depending on which way you look at it, they end up in the normal range. So one of the problems which Tanuja mentioned earlier is that comorbidities do influence where you land on that cutoff. So for example, BMI and age are major factors in terms of comorbidities in NfL readouts. So as neurofilament levels increase with age, you may actually have an abnormal test result at a younger age, but still be within the normal cutoff if it's done too conservatively. So in a way, this is probably not the correct thing to use right at the outset. So an absolute value at the outset may not be informative as far as the test results concerned. And there comes this concept which has existed for some time with other measures, such as BMI, for example. We do use Z-scores, which factor in various comorbidities, such as age, for example, and we may be able to use that for NfL values. So a Z-score is where you look at how deviated the test sample is away from a normal reference range, and you can factor in the actual confounder into that calculation. And that may be more appropriate for a single time point measurement. But for those who are still stuck on this idea of having just final absolute values, maybe there is even an option to consider even there, where you determine over a number of time period what is the reference range for that individual person, and then you can really look at the trajectory and change of that absolute value in that individual. That is possible as well if that is what you'd like to do. So for patients in particular, they might find it more useful or easier to understand to have an absolute value which they can track rather than a Z-score where it would be going in very minutiae change in terms of plus and negative.
So you saw we probably will get these on a normogram, I suppose, but which will be age specific.
Yeah, in the same way that, for example, your T-score for osteoporosis is calculated, but not everyone may like that.
So Tanuja, coming back to you, you did say that correlates extremely well with MRI activity and relapses. So do you think we were able to get rid of the MRI scan and just use neurofilament for monitoring?
Yes, that question has been tossed around, but I do not think that we will get rid of the MRIs. I do think that they're a critical part of both MS diagnosis as well as ongoing monitoring. But I think what NfL offers is an additional window into what is happening to my patient in between MRIs. We can only do MRIs so often in various locations. We do them generally annually. In other areas in the world, it's even more infrequent. So NfL does offer the ability to look into disease activity on an ongoing basis in patients. And generally, the recommendation is to measure NfL every 3 to 6 months. And this is where we know that it associates with new enhancing lesions. The trajectory is about 3 months after a new enhancing lesion. NfL is still somewhat elevated, and so it would be reasonable to measure it every 3 to 6 months to help to monitor patients and disease activity, occurrence, response to disease-modifying treatment. So I think it offers an additional window into what is happening to patients in between MRIs.
So do you think it could be used to distinguish between relapses and pseudo-relapses then, at a crude level?
I think so. It's a very good question around pseudo-relapses. And, we define them in different ways. There are heat-related pseudo-relapses, which are very transient. There are pseudo-relapses that may be due to fatigue or infections. But there may be some additional biology that's happening with pseudo-relapses. So I think we have to be careful in saying, one biomarker can distinguish between pseudo-relapses because they're quite a heterogeneous group and there may be different biology going on with pseudo-relapses, maybe expansion of lesions or inflammation around a lesion, or just Uthoff's phenomenon versus brand new lesions, which NfL is best at reflecting. So, possibly it reflects or it better reflects brand new gadolinium enhancing lesions associated with relapse, but there's still a lot to be learned around the biology of pseudo relapses.
So, Ahmed, can I challenge you? How about a new term, biochemical relapse, one associated with the raised neurofilament levels?
That's an interesting term, Gavin. So biochemical relapses, as you would define it, then it would be something where we see an elevation in NfL. But the question is, does it correlate with the clinical symptoms or clinical signs? So in the clinic, when I see my patients, on a daily basis or routine basis, sometimes we have people say, well, I feel worse. I'm getting worse. I think I have a relapse. And then, sometimes when in a resource limiting setting or in a resource abundant setting, we may obtain an MRI, right? And then we look at the MRI and say, oh, let's see if there are new lesions, if there are contrast enhancing lesions, if there are any changes that we can identify. And often we don't find changes. And if we have an elevation in NfL associated with those symptoms, then I'm actually more inclined to call this a relapse. And as you termed it, maybe it's a biochemical relapse and a clinical relapse. So maybe we can have a term called biochemical clinical relapses, and those will have an elevation in NfL, will have clinical symptoms and clinical signs maybe, but also may not have an actual changes on MRI that we can see. So that's an interesting term, and I may start thinking about it more.
Yeah, just to give you an example, I had a young woman who was on a highly efficacious therapy, and she'd come in with a new symptom. She had a buzzing sensation on her buttock, and she said she had a prickling feeling as well. When I examined her, I couldn't find anything. So we scanned her neuroaxis brain and caught no new lesions. And so I told her she wasn't having a relapse. She was not convinced, so we offered her a lumbar puncture. And when we did a CSF analysis, she had really high neurofilament levels. So this is an example of a biochemical relapse associated with symptoms, not documented clinically or on MRI. And that result alone led us to switch her therapies. So this is an example of how neurofilament monitoring in clinical practice affects decision making. Now, Sharmilee, there are now quite a few different assays coming onto the market. I think the space is getting quite competitive. Are you comfortable with these commercial assays? Are they reliable enough in terms of their performance to be used in clinical practice?
So for any test to enter into clinical practice, there needs to be a validation set which you run where you think it's biochemically robust, to adopt your earlier term. So it needs to be quite consistent from day to day to lot variation between the kits. And that's really the responsibility of the lab providing the test to determine whether it is feasible for use for clinical practice. Now, clinical validity is a somewhat different concept, and you may be able to say that the test itself is clinically valid because it has proven clinical use, i.e., a neuronal injury is marked by NfL release, which then leads to GAD enhancement and therefore also a clinical deficit in the long run. So that is a way of demonstrating clinical validation. I don't think you need to do that with every single test and assay it's there, because actually that's already been proven. So what you're trying to do is compare between their assays and see if there is a sufficient correlation to allow one test to replace the other. Now, this needs to be done at a laboratory level, and it's not a given that each assay will correlate. And if it doesn't correlate, there needs to be an understanding of where it doesn't correlate.
So I think from our listeners' perspective, we've just got to, assume, and I'm sure this would happen, that a good laboratory would have done all these things and the assays coming out will be reliable. So I think this is a very good point to take a break, and we will come back with part 2 shortly.